Welcome to the On the Pen, the Weekly Dose podcast, your one-stop shop for obesity medicine news with your host, man on the pen, Dave Knapp. Welcome to this Tuesday, April 22nd edition of On the Pen, the Weekly Dose podcast. I'm your host, Dave Knapp, man on the Manjaro. That's why I'm here. You are on the pen. Wegovy, Saxenda, Victoza, Trulicity, Manjaro, Zepbound, Compound, that pen. We bring you obesity news from the patient perspective each and every week with this podcast, a podcast that is steady in the top 20 of all podcasts in the United States for medicine. Thank you. If you're listening and tuning in today and you enjoy the content, please consider giving it a 5-star rating and a nice little review. That really helps the podcast. I appreciate so much to those of you who have already done that. Now, if you are subscribed to On the Pen email alerts over at onthepen.com, you learned early yesterday morning, the headline was that Novo Nordisk's oral version of Wegovy is almost here. We'll learn a little bit more on their upcoming earnings call as to how close that is to FDA approval, but they did confirm yesterday that 50 milligram, the high doses of Rybelsus, the oral semaglutide product, have been submitted for approval for obesity, and that would land Novo Nordisk's Rybelsus, and they'll likely rebrand it to something else. But the pill version of semaglutide will be available for obesity treatment probably within the next few months. So that's huge news. But everybody's asking one question, right? So we hear this news, and yeah, it's great to have more options. You're going to get Wegovy level results out of a daily pill instead of an injection. Awesome. But the question for everybody remains the same. Nothing changes when we talk about any news related to GLP-1s. It's who's going to be able to afford it. And here's the truth. Pills aren't going to fix this, not without pressure and not without a fight. And so that's what I want to talk a little bit about today. That's exactly why we're going to Washington, D.C. this week, actually. We're going to sit on a panel with the Obesity Action Coalition. We're going to meet with some key lawmakers and lobbyists who need to understand what patients are actually facing and what the threat really is to the United States if we don't deal with this in a meaningful way. So let's talk about for a minute what's coming. If you missed the article yesterday, Novo has officially submitted oral semaglutide for obesity. You know it as Wegovy, the once weekly injection of semaglutide. That is the same molecule that is in a pill called Rybelsus, which is a semaglutide pill for the treatment of type 2 diabetes right now. But basically, Novo cranked the doses up from the high dose of 14 milligrams, which is what's available now, to 25 and 50 milligrams in a recent clinical trial that successfully ended in 2023. So it's the same molecule, but a higher dose in a daily pill. One of the most effective weight loss drugs we've ever seen will now be available in a pill form. That's big news. Then there's Lilly's Orforglipron. This is a totally different beast that we've talked about. There are several videos that you can find on our YouTube channel. There are several articles at onthepen.com, and of course, several podcasts that we've done on the topic of Orforglipron. It's not a peptide, so no refrigeration is needed, no injection, no enhancer like with Rybelsus. Rybelsus needs basically this $2 billion technology that Novo Nordisk bought just to get a little bit of efficacy out of the peptide. So Orforglipron is a small molecule GLP-1. It's made to basically just go down easy and work hard and not get destroyed by stomach acid. That's the beauty of the small molecule. And Lilly isn't waiting for approval. We've brought you the news over the last few months that Lilly has stockpiled inventory of Orforglipron already to the tune of over $500 million. And they've obviously already built out the manufacturing plants months and months and months ago to build this inventory. So they are going to go quick and they are going to go big with Orforglipron. But what is the likely reality of the cost versus the hope that we have with these new options? So yeah, we're excited. I get it. A pill is easier, maybe cheaper, definitely more scalable, maybe more accessible. But here's what I think we need to understand. Just because it's a pill doesn't mean it's a fix. Novo and Lilly are already selling, and I think they would argue this and have argued this in the court of public opinion. But in reality, it is my firm opinion that Novo and Lilly are selling every unit they can make of Wegovy and Zepbound. They don't have excess supply. They don't need any extra motivation to cut prices. There's no market pressure when the demand is already greater than the supply. In fact, I believe it is the pressure that the compounds or the threat of compounds cutting into that is what gave us Lilly Direct and Novo Care, which both circumvent and disrupt the current broken system by circumventing the PBMs. So they added some market pressure, which was great, but they've been massively disrupted by the shortages ending of both semaglutide and tirzepatide. And also, let's not forget that these are the same two companies that were accused of price fixing insulin. Both companies were sued by the state of California. Other states followed suit. Both worked heart in hand with PBMs to inflate the cost of insulin. That was basically what they were accused of. And ultimately, when that all kind of came to light and public pressure was put on it, it caused lawsuits to stack up and caused them to ultimately cave and cap the prices on insulin. So you think they're suddenly going to compete on price out of goodwill? I really wouldn't hold my breath for that. So let's go back to oral semaglutide, Rybelsus, whatever they end up calling it for obesity. Maybe that's a good video for tomorrow to do. I've actually got some interesting stuff I've been working on this week. That drug already exists. It's FDA approved for diabetes. And here's what most folks don't know. It's hard as heck to make. You take it every day. It requires special coating, a stomach buffer just to survive the digestion process. And most of the drug gets destroyed before it even works. Like I said, Novo paid $2 billion for a technology that gets about 5% bioavailability out of that 50 milligrams of semaglutide. So it takes a massive amount of active pharmaceutical ingredient to make Wiggoi. And now that you're exponentially increasing the amount of API, listen, 50 milligrams a day versus 2.4 milligrams a week is a lot more API. I believe it's like 145 times the amount of API to produce similar results. And we learned recently just how big of a deal that is when we sat down and interviewed. I'd love for you guys to go watch this interview because it's amazing. We interviewed a group of students from the University of Ottawa who were participating in this amazing event that takes place around the globe with folks that are looking at biofarming, like biofarming with a PH. And they basically found a way to reproduce liraglutide, which is a precursor to Ozempic semaglutide, and they reproduced that protein in a plant. And it's an amazing story. And so they did that. In part of that conversation, they did that because the process of manufacturing semaglutide and liraglutide from yeast is extremely expensive. It's extremely inefficient, and it's very hard to scale. That's why I believe, one of the reasons I believe that Novo has deprioritized this over the last couple of years, because it's a lot of squeeze for not that much juice. You think about the fact that there's 145 times the amount of drug in a weekly pill to get the same effects as you get in a once weekly shot. That's a lot more juice to squeeze, so to speak. So going back to Orforglipron, that kind of changes things, right? Because Orforglipron is different. The one thing that it has is that it has a shot at being manufactured cheaper and being sort of easier on the manufacturing process from a waste standpoint. It's still somewhat complicated to make as a small molecule, but certainly easier with less waste than the yeast-based process. And it's a simple daily pill with strong efficacy. But will it open up the floodgates? Like, will this really expand accessibility and drive down price? Not unless we change the rules of the system that it's being dropped into. because Orforglipron is still under patent. It'll be under patent for a long, long time. It'll still run through the broken PBM system, presumably, and maybe they end up offering a cash pay price through Lilly Direct. We'll see. But it's still going to have us stuck with the same formulary and insurance games that make Zepbound completely unaffordable for many, many people, millions of people who need it. So all this is playing out while there's this lawsuit that could flip the whole board, right? And we don't talk about this too much because not a lot has happened, and it hasn't seemed like this lawsuit is likely to go the way of the patients, but it's still going on. In fact, this Thursday, we have a massive hearing in the tirzepatide lawsuit. We're going to bring you wall-to-wall coverage on this. In fact, hopefully we'll be able to bring you another interview with Lee Rosebush if we can pin him down this week. But basically, the Outsourcing Facilities Association suing the FDA over pulling tirzepatide and semaglutide off the shortage list. And that move instantly shut down compounding and access to many, many patients, forced to move to some custom dosing, custom formulations. And we're seeing some wild stuff this week. So check this out. Just yesterday, it was sent to me. There is a telehealth company. I know many of you are going to go seek this out. I will not mention who it is. You're going to have to do some research on this if you are the squirrely kind of cat that likes to go and try the crazy stuff. But listen, because custom doses and custom formulations of these drugs are the only way to sort of get around compounding right now, you saw this week a telehealth company launch a version of a GLP-1. They're calling it like GLP-1 squared or something like that. And it's a mixture of semaglutide and tirzepatide. Wild. At the high dose, it's like 13 point something milligrams of tirzepatide with 2 point something milligrams of semaglutide at the high dose. Wild. Just wild. Nothing like that has ever been tested. And it is, I mean, this is what things are coming to, right? Because compounders have to get creative in order to continue to offer access to patients. They have to offer something that's not commercially available. And so these are some of the answers that we're getting in some of these far reaches of telemedicine, which, I mean, I don't even know what to make of it right now. But the 503Bs ending the mass compounding of essential copies of the branded versions was essentially the firewall. That's what provided so much access to copies of these medications to people, and it was shut off. And so they still have a little bit more time left on semaglutide, but I mean, so much hinges upon what's going on in federal court down in Texas, and so much hinges on that. And so we'll continue to follow that closely. But if you missed an interview from about 2 weeks ago, we sat down with the CEO of Noom. Now, Noom is a telehealth company, focuses on lifestyle modification, trying to get to some of the root causes of overeating, etc. A really interesting program they have there. But CEO Jeff Cook on our podcast talked about a proposal that he has that I think we can sort of get behind. It's basically the idea that if a drug costs twice as much in the US as it does overseas, then it goes on to a special list of overpriced drugs, and 503B compounders should be able to mass manufacture it, right? It is an answer to a system that leaves way too many people on the margins of getting treatment because of, well, some might argue price gouging, right? So how do we, it's always this dance of how do we protect innovation, which is an important conversation to have, but how do we protect innovation without saying whoever gets left out and whoever gets left to the margins sort of be damned, right? We have to address this. I think that this is a modest proposal from Noom CEO Jeff Cook, and I think he's right. We need a system that rewards innovation but doesn't punish patients for being American. Because right now we're paying double for the same drugs made in the same plants, delivered in the same pens as they are in other places in the world, and it just ought not be that way, especially when our public dollars were designated to help develop the science behind the treatment to begin with. It's wild, right? So that's why I'm headed to DC this week. I'll be on a panel with the OAC, speaking alongside some experts and advocates that understand that this just isn't about new medications, although we get very excited about that here at On the Pen. It's about fixing a system that seems to block access to patients at every turn. And I've got meetings lined up with lawmakers, industry lobbyists. We're going to talk about compounding. We're going to talk about shortages. We're going to talk about the real world effects of PBM contracts and how they are absolute legalized corruption in this country. And I'm bringing your voices with me because this fight isn't abstract. It's personal. It's medication or no medication. It's hope or despair. It's shots, pills, or nothing at all, or worse, research grade, which is just a whole nother conversation about where so many people are going, and so scary to think about the lack of regulation there and the wide scope. Like, you can believe what you want to believe about research grade medications, but we can all agree that people should generally not be taking medications without doctor supervision. One of the greatest issues that we have with compounding is that people over or underdose, right? And that problem alone is massive. So when you think these people are taking research grade without doctor supervision, they don't know how much they're taking often. People get so confused. Anyway, it's a whole rabbit trail that I don't even intend to go down today. But I think it's important to just know that there's a fight to be had here, and there's a ripe opportunity to get some things looked at, changed, and understood. And that's what we're super focused on here at On the Pen right now. We will be updating you all week in Washington, D.C. I'll keep you updated on what kind of talks we're having. And we'll obviously be watching the OFA, FDA, Lilly case down in Fort Worth, Texas on Thursday. Hopefully bring you some great content on that. Thank you for being here. Thank you for being the best part of what we do at On the Pen. I couldn't do this without our sponsors, Row. Shout out to Row, who have a wonderful program called the Row Body Program, where patients enrolled in the Row Body Program lose 15 to 20% of their body weight in a year when coupling these medications, when medically necessary, with lifestyle modifications. The Row program has it dialed in. And especially if you're somebody who's lost access to compound, listen, I'm hearing at a clip of every day now. Every day I'm hearing from patients who are jumping on with Row and taking advantage of the fact that they know how to fight for prior authorizations. They know how to say the right things to the insurance company, present the right information to insurance companies to make that process as efficient and effective as possible. So if you're somebody who's facing a loss of access to a different kind of these medications and you're taking another look at branded, look at our friends Row. Visit row.co/OTP to learn more about the Row Body Program, and click around and find information about the potential side effects of GLP-1s. If you're looking at getting on one, always make yourself aware of the fact that there's no free lunch. If you're going to take something, there's usually some sort of trade-off, and you should be aware of what those potential side effects are. Visit row.co/OTP. Thank you for being here, and we will catch you on the next one. Thanks, friends.